get quorum and start your discussion. And
You
we have the
record, I go live. Give me
Okay.
5 seconds. I go
Yes.
first.
You go first.
Okay, there we go. Great, glad to be here. Thank you for having me. We have our Accountable Care Organization annual sole member meeting. I believe we will defer the resolutions and approval of the minutes. Is that correct, everyone? So with the board chair's permission, I'm Matt Siegler, the CEO of the ACO, and I'll walk into our presentation. Next slide, please. Thank you, sir. This is our agenda for today. We have our minutes that we'll defer. I want to make an important introduction to those who haven't met him of our Chief Medical Officer. Then I'll walk through our performance results from the most recently completed year. We'll talk a little bit about how our ACO compares to regional and national trends, a little bit about what that indicates about where next year's trends may be headed, and then talk a bit about our future at the ACO, some of the key clinical initiatives we are working on, and where our focus is going to be in the year ahead. So first and foremost, I want to make sure you all meet a key member of the team, the real leader of the ACO day-to-day. Dr. David Stevens is the Chief Medical Officer of the ACO. He is also the Chief of Ambulatory Care at Kings County Hospital. When I came into the ACO, it was very important to me that our Chief Medical Officer also be a practicing physician in health and hospitals. David is certainly that and is a leader of one of our largest and most important hospital-based ambulatory care practices. So he brings a wealth of knowledge and the real ability to look at everything we do as something that must be implemented in actual patient care. And that sounds like an easy thing to say, but it's a critical part of the way we operate successfully as an ACO, and I think about this type of work. So welcome, David, and he'll speak to you more later on about our clinical initiatives and our path forward. So performance year 2019 was a tremendous one for the ACO. We generated more shared savings and earned performance payments that were greater than all but 1 year in the history of the ACO. So it's a tremendous success. And the ACO overall has earned performance payments for 7 consecutive years while improving the quality of care for the patients we serve. So it's a tremendous record of accomplishment, and our small team, and more importantly, the providers and their teams on the ground at all the facilities should be very proud of it, and I know they are. So this year was different for several reasons. The first, just as some folks may remember, we made the decision under Dr. Chosky's leadership and with this board's participation to move into track 3 of the ACO model, which is both an upside and a downside risk. So we have the potential to have to pay back money to CMS if we are not successful at generating shared savings, but we also have the benefit of recouping a larger percentage of the shared savings we generate if we are successful. This change went into effect in the middle of the performance year. That's why in the chart you see 2 columns for performance year 19, January through June and July through December. And the impact of it was significant, generating double the performance payments for the second half of the year versus the first. The change also comes with an important one, I think, from a care delivery and a strategy perspective, beyond just a financial one. It changes the beneficiary assignment from retrospective to prospective. So we now know at the beginning of the year who our ACO members are and what we should be doing to take care of them. We had a rough idea of that before, but a lot of the assignment was done after the fact in the prior model. So now we have that clear picture. It makes our attributed assigned beneficiaries decline slightly, as you see, from 11,000 to 9,000 as the year goes. But we think that 9,000 or 10,000 number will remain stable in the next year, and we have the opportunity to grow it. So a great successful year. Next slide just goes into a bit more detail on what I was mentioning, how the two halves of the year compare. You see we have larger total savings in the second half of the year, but then have a significantly higher final sharing rate, and thus a higher performance payment. Next slide. So our quality performance remained strong in 2019. There were changes as a result of some key interventions we take to address a prior corrective action plan. Overall, our patient and caregiver experience dropped slightly. Our care coordination and patient safety improved significantly, and the other two measures I'd say were roughly consistent. So all in all, a good performance, and CMS's approach to this, given the impacts of COVID, has been very friendly and helpful to us. So we expect, as we continue to drive this performance on our own, we will have some leeway and flexibility in this year, which is very helpful given the circumstances. So this next slide provides some background on why we were so successful this year and why we think we will be successful in future years. The bottom line of it is that our ACO provides very efficient care, much as Health and Hospitals does overall. The top chart shows how our ACO's growth in spending has changed over a 2-year, from performance year 18 to performance year 19 versus national and regional trends. So a 1.9% growth rate in spending is dramatically low in the overall context of healthcare spending, as many of you know, and certainly compared to our peer organizations regionally and nationally, it's significantly better. The chart on the right shows how much our overall spending changed over a 2-year period, and that is largely driven by the significant impact of removing the costs associated with COVID-19 treatment. Another way of looking at that, or what drives that chart on the top right, is the chart at the bottom, which shows just the sheer percentage of care and spending that our ACO provided this year that was COVID-19 related. 12% of our overall spending compared to 7.6% regionally and only 1.85% nationally. So the ACO is efficient overall, and it managed to be efficient even in the face of dealing with a dramatically disproportionate amount of COVID-19 spending. So beginning on the next slide, David and I will sort of split and talk about this. We wanted to take the board through a little bit of what makes the ACO successful, what we view as our core role, our core functions, and how we want to build upon that to serve our members, to serve the broader community, and to help inform and build upon the success of Health and Hospitals overall in its value-based payment and care delivery model. So the core model of the ACO is really a small, nimble central team that has extensive expertise that I'll go into, and then dedicated clinical leads at each of the facilities. These clinical leads are not dedicated in the sense that they spend 100% of their time on ACO patients, far from it, but they are a group of clinical leaders who have committed to this work and who are interested in our monthly gatherings, learning together, shared issues, focusing on continuous quality improvement. And they interface with their care teams at the clinical sites. And so that is the basic relationship. Our central team provides timely patient-specific data to the clinical leads and their care teams. We support them on implementing best practices or expected practices, and we notify them with regard to changes in CMS rules and contract policy. That's the basics of what the central team does. There's a lot that goes into it, and it's a small team that does a tremendous amount of work, but that's the core of it. And then what we look to our clinical leads with in the sites, in monthly meetings and in ad hoc touch bases, is to bring back systemic challenges that they face in improving care, to provide feedback on project implementation, and to give us insights on the quality and level of detail on the data we provide. And it's a good, important, virtuous cycle that has benefited our patients over the 7 years of the ACO. Now, David was a clinical site lead at King's before he became the CMO, so I think he has special insight into this. And David, why don't I turn it over to you to have some comments on this and take us through a few of the next slides.
Sure. I just want to talk a little bit about what it is that our site leads and the care teams that they work with are doing. This is not something that has been standardized, and I think there are strengths to that and there are weaknesses to that. But at each of our sites, there's one or often a full team of facility-based staff that are looking at the data we provide them. And the data is provided both proactive, we periodically give them a list of patients who are at high risk, and reactive, we give them a list in real time of patients who are in a transition, either from the inpatient to discharge or from the emergency room to discharge. So the facility-based teams reach out to these patients, make sure they're engaged in effective care. When they are engaged in effective care, but they're still experiencing a lot of hospitalization and ED use, they try to unpack it further. Are there social challenges that they can help the patients with? And so, to whatever extent we've seen success in reducing costs for our group of patients, it's because these facility-based teams are taking the data that we've been giving them and putting it to good work. In the time since I've been on the team, which is about 6 months now, I've been paying attention to what the facilities really want from us beyond just the data. And as Matt said, being on the facility side for 98% of my H&H career, I have a wish list that I feel like central office and the ACO team can help us on. And so we've been getting a lot of feedback it's helping us put together a list of projects that we think will help the ACO continue and build on its successes. So I think we can move to the next slide. So this is a diagram that kind of explains in graphically how we see our role. The central ACO team is sort of this funnel that takes all the different players that are also thinking about these same high risk, high utilizing patients, and how do we make sure they're all talking to each other, that the care is integrated, and that there are standards that live throughout our system to produce at the bottom better outcomes for patients with chronic advanced illness and increased risk revenue. So who are these players? And this is really not a complete list, but this is the main one. So there's the Office of Managed Care, because we do see our charges not being limited just to Medicare, straight Medicare beneficiaries, but all H&H patients who fit into this chronic advanced illness category. So we're partnering with the Managed Care Office, as well as the payers themselves, MetroPlus and Health First. We've had numerous conversations with them, understanding how our clinical sites can partner better with the payers to deliver on the promise of integrated care. There's community care. They are equally dedicated to this mission of improving care and keeping people out of the hospital. There's the clinical councils. Most significantly lately for us has been cardiology, and I'll talk a little bit about that as well. But the clinical councils are thinking about these problems as well. The Office of Ambulatory Care is thinking about them from the population health perspective, but also just on the standardization of care perspective. And then there's our long-standing colleagues, the ACO clinical leads, who are thinking about these patients as part of their job and have come up with some ideas about what we can do better. So that's our focus. That's how we see ourselves, and our part in the ACO team is making sure all these players are aligned to reach the goal of better care, better outcomes for chronic illness, and again, increased risk revenue. Next slide. And by the way, please go ahead and interrupt me at any point if you have any questions or suggestions or comments.
Can I ask you a quick question,
Absolutely.
David Sopagan, with the change that Matt talked about from retrospective to prospective selection, you have 9,000 ACO members that you take care of. How does that change the strategy that you follow, keep people healthy? And I'm specifically interested in knowing more about, like, does it allow you to, because you don't have to worry about where they get their, I mean, they already assigned to you. Does that allow you to do more activities that are outside the healthcare delivery side, or?
Yes and no. The no part is the old payment model didn't restrict us from doing activities outside of the conventional. But what the new model does, it's just as we want to, as we create new interventions, we want to evaluate them, and we want to know what's working, what do we build on, what's not working, and having, from my perspective on the evaluation side, knowing who our population is from day one on the year allows us to really get a sense of whether what we're doing is working on the population that we committed to. Whereas if that population changes over the year, it really makes evaluation much more difficult. But in terms of does that answer the question?
Yeah, I was thinking about the examples where you have a patient and then the patient suddenly, because they don't get care with you, they get assigned to someone else, or they don't get assigned to you. And you could have been very good at prevention, and then the person is gone, right? So.
Yeah, exactly. And in some ways, this starts to look a little bit more like our managed care plans. There's still on the ACO side, patients still have complete freedom to get care anywhere they want. That's built into the model. But if we know who they are from day one, we can start to make sure we're meeting their needs, so they don't choose to get care elsewhere.
Thank you.
Thanks. All right, so that's a good lead into the kind of the some specific ways that the ACO is defining its functions. So first is expected practices for high-risk patients. These exist in pieces, but not in a rigorously implemented way across our system. We know that the Cardiology Council has developed standards of care for heart failure management. In other areas, such as COPD or dementia, there may not be standardized care models. We want to make sure that where they matter the most, the conditions that matter for the most, that we have standardized care models, and that these care models include, what medications you're on, what tests you're supposed to get, but also more broadly, what care we're supposed to deliver. Are you delivering the right access of care for people who are chronically ill? Are we bringing in community care where it's needed? So standardized care models that really wrap around the full patient set of needs. And then the ACO is committed to delivering coaching and support for implementation of these care standards. Some facilities will be able to read it and say, we're doing this already. Other facilities, this will be new to them, and we want to provide coaching and support for implementation. Number two is just on the quality measurement and side and intervention. We have to identify the care gaps. So on the managed care side, we've been doing this. We have a care gap tool that gets sent out, and so the care teams know what to intervene. We're doing something similar in a more focused way on the ACO. What do we know are care gaps, and we want to provide supports for addressing those care gaps. I'll get into that a little bit more later. On the data analytics side, this has always been a strength of the ACO team. We provide timely data to facilities on the high-risk patients, including transitions of care. And then we perform analyses on trends on developing trends so we can identify populations that need more specific targeting. And then there's administrative support that we're providing. It's challenging to me. I can't read the slides because I'm talking over them. But we invest our shared savings at the care sites. We do that in a number of ways. We have care team funds that go to the primary care teams. And then we have, as you know, the primary care physicians get a bonus at the end of the year. And this is important for physician retention and also letting the physicians know that what we're focused on. We interpret the Medicare Shared Savings Program contract policies because they are evolving over time. We want to make sure our care teams understand these, and as well as the board. And we perform impact analysis whenever there's a policy or rule changes so we can forecast the outcomes. Questions on this slide? Great, keep going.
Sorry, David, I couldn't find my unmute button. So I just have the question on the data exchange. Is it bidirectional where like the private physician or the community provider gets this data and says, you know, David, this data doesn't look right. There's a correction here. How do you address that?
Yeah, that's interesting. The primary data we provide is utilization data and cost data. So we get the Medicare expenditures and we share that with facilities so they know kind of which patients are the highest utilization. Our facilities don't have extra information on that, that they could kind of give us a correction. The second data source is time utilization, and that's ER, inpatient. Hey, your patient was in the emergency room yesterday, so you know. Again, we don't necessarily get corrections on that. One area where we theoretically could get corrections on is whether services that are part of our quality metrics. On the managed care side, we definitely provide a lot of correction because there are services that are delivered that for whatever reason don't get on the plan's radar. I'm going to follow up on that and make sure that we have a mechanism for getting that feedback on the ACO side, because I don't know that. I don't have a specific answer for you. I know what you mean, but I don't have an answer. I was going to ask you to answer your question, but I know it doesn't. But I'll get back to you on that.
Reassuring that we're thinking about it as an organization.
As an organization, we are definitely thinking about this,
Yeah.
especially in December,
Yes.
which is our deadline for meeting all these care gaps.
Yeah.
So there's a lot of work being done at the facilities. We do get care gap reports from central office as well as the plans, and do our best to meet these. Hopefully throughout the year, but definitely at the end of the year.
I just curious real quickly, is there, given the COVID situation, I'm thinking in particular about some of these care gaps, because a lot of them are addressed by routine visits and so on, or going to get a lab done or that kind of thing. Are we seeing, I mean, are we at real time at this stage of these last several months? Are we beginning to see some real issues and challenges with meeting these metrics, or have we been able to more or less keep up with some of that?
Yeah, I mean, I think some of the metrics are definitely squarely, in the target of what COVID impacted. I mean, if you were trying to get a primary care appointment this spring, you probably weren't able to get one. And so, if there are surveys of patients about access to a PCP, those are definitely impacted. It will be impacted for better or worse across the country. And CMS is taking this into account. On the utilization side, it actually looks like utilization is down because I think a lot of patients stayed away from the ER if they could. So I think COVID is going to help in some areas and it's definitely going to hurt in some areas.
And Dr. Calamia, this is Matt, just to weigh in. I think we definitely have seen that. We have seen some of these key measures drop off. And I think, just given where we are in the year and with rising cases, right, this, as David said, is the crunch time where my team, other teams are reaching out to all the facilities to say, here are the 100+ people you've got to get in for a cancer screening before the end of the year, we really have to reassess that, because we are in a phase where some of our ambulatory care staff, we're going to be asking people to do more visits remotely. We're going to have to look at redeploying some of the staff if cases continue to rise. So it will be a real challenge. The ACO program has been more out front and more generous on this than some of the Medicaid managed care plans. But we do expect flexibility on these things given the extraordinary circumstances this year.
I would add, as a ACO primary care doctor, both the positive and the challenge. The positive is I get a list often of care gaps for my medical group and get to look up and identify who are the patients where I need to do something. That's the positive. But I think even more, Matt, than what you're saying, sometimes I have to decide that I don't think it's worth the risk of my patient to come in to close that gap. I mean, I have to weigh, what it means, what their potential exposure is versus, the importance of getting that care gap closed. And it's, obviously it's different, especially for older patients or patients with comorbidities, where I know I and other primary care doctors feel very protective about them not coming into clinics. So it is a very complicated dynamic.
Thanks, Dr. Katz. And I think that also in other ways, we're providing services that are of incredible value to our patients that we don't measure, right? I mean, our pivoting to telehealth and increasingly video visits is something that we don't know how to CMS hasn't measured. So I think we are providing value, but not in necessarily the ways we're used to measuring.
And it's not like CMS is going to say, well, you didn't meet the metric, but you delayed something, and if it still save money and people are doing well, they're not going to go around and say, okay, we'll do an exception for you, right? Because they set up all this contracting beforehand.
Well,
Yeah.
no, I think if Sean is on the phone, he can weigh in with the specifics. CMS has been extraordinarily generous on this, and I think they have just said we will kind of hold everybody harmless this year and even potentially into next year. So it is a challenge, I think, for the overall, looking at the overall value of the ACO program federally, right? But for our purposes this year and for how it will affect our shared savings next year, it's certainly a helpful policy decision on their part.
Thanks.
Okay, so at a very high level, this is kind of how we see, this is our kind of model for work at the ACO. Moving from left to right, I mean, our first is we identify high-risk, high-utilizer patients, frail, elderly, palliative care, homebound. These are the folks that we really need to focus on. And we have great data on who they are and what their utilization is and what their risk scores are. Next, we have to build expected practices to meet their needs. We need more patient-centered approaches to meeting their patient needs. I think a model of care for these highest utilizing patients, highest need patients, is going to look different than the model of care for somebody who's generally healthy and just needs management of hypertension. We have to make sure we're addressing the social drivers of utilization, and especially the social drivers that affect downstream care, downstream illness. Things, food insecurity can be a long-term risk, but we're also finding patients are immediately using the emergency room as a way to get food. So being able to address the social drivers is critical. And then third, optimizing the management for chronic conditions. And this is something that the care for advanced chronic illnesses is really provided across the spectrum. How do we optimize the management so that it's really truly integrated? Once we develop these expected practices and implement them, the model is then we start to see some outcomes. We reduce utilization, which improves, we reduce utilization, keeping people out of the ER. And most importantly for me is we improve health outcomes. Patients will feel better. Staying out of the emergency room is a great way of helping somebody with an advanced illness optimize their life. And then there's organizational financial outcomes. If we meet those goals, we will decrease expenditures and we will increase our revenue. Once we do that, we can then feed the increased revenue back into better care. So that's how we kind of see the world at the ACO. So next slide, we'll start to tell you what we're starting to do about it. So if we take that blue box of just the high risk expected practices, there are 4 areas that we're targeting right now with improving the care. The first is the annual wellness visit. Annual wellness visit is a visit type that Medicare, all payers, Medicare pay for, and it really moves away from reactive care, but tries to see what is this patient at risks for. It looks at things like their ability to perform their activities of daily living, visual impairment, hearing impairment, fall risk, depression scores, things that the patient may not be coming to us complaining of, but if we don't detect them early and start to intervene, it puts them at high risk down the road. We've partnered with the Geriatrics Council to create clinical standards, and now we're partnering with the IT folks to build this into Epic as a standard note template that will facilitate getting the right care. And then we're going to partner with the Ambulatory Care Council to divide up the work, because one provider can't do 12 screenings in a single visit. But if we partner with our nursing colleagues, they can reach out to folks on the phone before the visit, screen them for activities of daily living and fall risk. That information comes into the PCP, who then sees what the patient is at risk for and intervenes. And then we can bill for that, and it's definitely a good source of revenue for us. Second is a high-risk patient community-based organization directory. We've found that a number of our facilities have become very savvy at using community-based organizations to intervene on high-risk patients. I mentioned before the patient who was using an emergency room at Woodhull really to meet their food needs. Woodhull partnered with a community-based organization that was funded externally to provide healthy meals for people with chronic illness. And that alone was all it takes to keep that patient out of the emergency room and really keep them much happier getting their meals. We've developed a list of CBOs that have been of help for all kinds of conditions, and we're sharing that across our system and building that into the EMR through our NowPow tool. Third is self-management coaching. All of our facilities are engaged in managing, in providing self-management coaching to high-risk patients, but they're all doing it in kind of different ways and with different resources. Some are using social workers, some are using PCAs or medical assistants, some use nurses, some are using their residents. We want to get those people together on a monthly meeting to start sharing best practices and start to identify their own barriers and where they need training, such as motivational interviewing, to make sure that they're all providing the best care to integrate, to engage and support our patients in self-management. And then the last is CHF. CHF is by far our leading cause of what we think are avoidable emergency room and inpatient use, as well as readmissions across our system. We've got some really smart people thinking about heart failure on the Cardiology Council. We also have the home care folks who are thinking about it. We're going to partner with both of them to make sure that there's standardized care, that patients with heart failure, wherever you're getting care in our system or in our partners, that the care is fully integrated, that you're getting the right medicines, getting the right education, the right home care, and that and that you can pick up any chart and be able to prove that all these patients are getting the standard care for heart failure. We're really excited about this, and it's opened up doors working with the Cardiology Council and home care, and we're looking to put a lot of effort into this in the coming year. Questions on that?
Yes, just one quick question. Basically, because you're talking about obviously the patients who are super utilizers. Sometimes you focus and you can find some of the physicians have a record of perhaps also having very high utilization, and sometimes even their quality, metrics are lower. So really two questions. One is the issue of, how do you help to try to educate or monitor or provide, some sort of assistance to that group of physicians? Are you looking at them carefully? And actually, the other point would then be for some of these patients, although we want to make all the practice, as you say, conform to certain models, are we looking at perhaps diverting some patients to more highly specialized or more, shall we say, efficient and effective providers in order to approach that? So kind of both areas to sort of comment on, if you could.
Yeah, I'm going to answer the first question, and then I have a question for you about your second question. So the first question is really, can you track some of this high utilization back to individual primary care providers who seem to have their own clinical practices that are not consistent with best practice and with best outcomes and with optimal utilization? We have some history of doing that in on the chronic disease level in ambulatory care, specifically hypertension and diabetes, which are really kind of upstream chronic illnesses for the ACO. On the downside, in the more advanced chronic illnesses, again, we're focusing on heart failure. We have not done that. We have not had a way to collect data on specifically on heart failure best practices. Are they using the right medicines? Are they providing the right education? Are there right referrals? We haven't collected that information around heart failure or other advanced illnesses to date, at least not that I'm aware of, and I've looked. So I think the first step there is being really super clear on what are the expected practices. Once you have that, you then enabled the clinical managers at the various sites. You give them a tool for them to say, all right, I'm looking at 3 of your charts of patients with heart failure. Are you meeting the standards? Are you using the right medications? Are you referring to to cardiology for an annual assessment? So we need to create those care standards, and then that will really empower our facility leads to do that work. That work has been done in diabetes and hypertension, and I think we're ready to start doing it in more advanced illnesses. So that's the answer to your second question. Your first question. Your second question is, have we considered referral to more efficient models? And by more efficient models, do you mean kind of within our system, or do you mean outside of our system?
Well, I'm thinking hopefully within our system where we've got maybe, a team that is a little bit more, like I put it, advanced in their ability to track patients and their ability to, and their track record, both from outcomes and from quality availability, because sometimes it's, why are certain practices, patients tending to go to the ER 3 times more than other practices? And part of the answer is availability of those practices. So again, whether we develop sort of specialized centers within our own group or not, I think that's really what I'm looking at. I know I'm aware there are some outside entities that kind of do this sort of ambulatory ICU type of situation, and I was thinking more of internally having something along those lines, or at least certain providers that are more specialized perhaps in following those CHF patients, those diabetic patients, and so on, some of the chronic diseases that seem to produce that high utilization?
Yeah, I think the answer is will never be like, optimal providers. The answer will always be an optimal team. I think we've learned that in other chronic illnesses, certainly in diabetes, also in HIV. We've learned that we can sustainably deliver great outcomes if we take a data-based approach and a team-based approach that intervenes with the patients who we have data that need extra help, and we provide that extra help as much as it's needed. Those solutions work. We're not doing that consistently with heart failure. When I talk to the Cardiology Council, talk to different facilities, there's a lot of variation. I can say that all of them know about it and want to do it. But I think they need some support in building it. And I think that starts with the data, because we don't have a single robust heart failure registry at this point. It exists theoretically in Epic, and it's on the work list for IT. So that's definitely in the works. And once that's out there, we have to support our facilities in understanding how to use those registries to evaluate individual patients' care, evaluate themselves as a practice, and see where their gaps are. But I think ultimately, certainly all our acute facilities need to be those model practices for heart failure. We know what that looks like. It's just a matter of how do we build it. And I think the ACO is in a position because we can link cardiology and the cardiology clinics to the home care folks, to the primary care folks, to the ED, and make sure that any given patient is getting the right care. But we have to be able to do this ourselves. We've done it with HIV. We're increasingly doing it with diabetes and hypertension. We have to do it with heart failure. Does that answer the question?
Yeah, it does. I appreciate that. And I don't want to monopolize here, but one of the last quick thing, and don't have to get too detailed on it, but a big chunk of this is going to have to do with, again, as you mentioned, making sure the patients are properly taking their medications during the transition from a discharge from a hospital or just in general. And I'm just wondering, do we utilize pharmacy in that way, either clinical pharmacologists, or are we looking at that aspect to be certain that we have that coordination with the medications?
Yep, we're definitely looking at that. The Cardiology Council has defined that as an evidence-based practice, that bringing a clinical pharmacist into the picture to do medication counseling around the discharge period has been something that's been shown to be effective. Where we are working with a couple of other players downtown to look at if this is something that we can fund. I think there's other pieces. I don't know that it's necessarily you need a clinical pharmacist. That's my personal opinion. I think home care, bringing a home care nurse into the home to do that counseling, just to me makes common sense that would be equally effective and probably more effective with some patients. But you have to have really highly trained home care nurses to do that. So that's another way to deliver that care, that we're working with home care. And I could say our home care team is very engaged and really wants to be a part of this. So thanks for that question.
Thank you. Appreciate it.
Other questions?
Well, this is Matt. I mean, we're happy to take other questions. I think just two things I'd say to kind of sum up and thank David, especially looking at this last slide. The One City Health, our performing provider system under DISRIP, is also part of my team, and then my team works on all of our managed care contracts and the quality and performance under those contracts. And so, this list of clinical initiatives for the ACO, I'm particularly excited about and pleased with, because it learns lessons from those other venues, and it also presents us opportunities to improve in those other settings, right? So both of those places, particularly one city, we had a lot of experiments around some of these things, around social determinants of health, around integrating with community care, and the opportunity to focus on that with a clear and relatively fixed population of about 9 or 10,000 people, compared to an overall attribution in one city of several 100,000 people, or a primary care panel across primary care membership across health and hospitals of over 400,000, is a great opportunity. And so we are focused here. We are looking again at a Medicare population with advanced illness. So we are not trying to boil the entire ocean of the needs of health and hospitals patients, but it's an important opportunity, and these patients are a cost driver and a health risk across both the ACO and everything else we do. So it's an exciting time for the ACO, and I'm very pleased to lead it and have David and the team's partnership in doing it. So if there are no other questions from folks, or Dr. Pagan, were you going to ask something? Sorry.
No, well, I just wanted to just commend you and your team and David and Matt, all the work that the ACO has done. You know, you're also standing on the shoulder of giants too, people that have worked on this for a while. But more than anything, I look forward to learning more about like how all the lessons learned from the ACO translate into activities at H&H, and keep doing the great work you're doing. It's a nice way to end the year. So
thank you, sir. We appreciate it, and we look forward to an education session with you and any other board members who are interested in what the ACO is doing, how it relates, overlaps, informs, and learns from what we do in managed care and one state. I think that'll be a great opportunity. There are some important things to discuss. Given that we don't believe we have a quorum for the board, I think we are going to ask to defer the resolutions until a January board meeting when there is quorum. But just for folks' awareness who are here, this is our board of directors of the ACO. Notable addition is Nicole Jordan Martin, who leads our community care division. We asked her to join. We had a lot of partnership with her on care models, and we're thrilled to have her join as well. But we will defer the resolutions to January, and if that works, we'll give you a few minutes before your 2 o'clock meeting.
okay, thank you guys. Bye.
Thank you so much.
Thank you. Be well, everyone.